Ladies and gentlemen, it truly is an honor to be invited to come and give this lecture today. And it's a pleasure to be in such a beautiful and sunny city as Berlin. Almost as good as Edinburgh. I'd like to start by saying thank you to Emily and Julia for looking after me so well in relation to getting me here. And of course the ethics task force of the Einstein Center for issuing the official invitation. So you can see the title of my talk. I would just like to say that I will be leaving the slides, so if anyone wants them, they can have them. Emily's got them, so just make a contact and just take them. If you use any of them, just acknowledge where you got them from. That's all I ask. Right, the first slide shows is a little copy of the front cover of my book with the title given there. I brought a demonstration copy. I think it's on a table out there. I don't mind if it's circulated. It'd be nice to go home with it, but that's not absolutely essential either. It won't be the first demonstration copy that's gone somewhere very valuable. I'm going to start by just pointing something very obvious out, that we are one species, and there's no doubt about it now. That's not true in the past. Firstly, there were about 3 species of human beings on the Earth about 25,000 years ago. We forget that. Now there's only one. Don't ask me what happened to the others. This idea that we are one is quite newly established. Certainly until the beginning of the 19th century, there were very big debates on whether we were many species or one. The argument was called polygyny versus monogeny. One of the most important players in this argument was Johann Blumenbach, a German. I'm sure his name is very well known to members of this audience. If it's not, then please do make sure you learn about him. Some years ago, about 10 years ago, I wrote a paper called The Beautiful Skull and Blumenbach's Errors. He was about 200 years ahead of his time. He believed in the equality of all human beings, and he more or less established that we were one species, that all this talk of many species was wrong. That doesn't mean to say his work was perfect, far from it. And if you don't have the time to read his 3 dissertations on the topic, then you could read my paper, and the references to that paper are in this series of slides at the end. So you can see his portrait, and you can see his most of his work was based on skulls. I was delighted to get a letter from his great-great-grandson, which the BMC also published. In this letter, he says, "Thank you for restoring the reputation of my great-great-grandfather, because he's been associated with some of the terrible traditions of pseudo-scientific work on the classification of human beings." Blumenbach is one of the very few people who fervently believed that Africans were the equal to Europeans, and wrote a whole chapter on that topic. As I said, he was 200 years ahead of his time, and Germany can be very proud of him. What Blumenbach couldn't see is what we can see here. We were walking in the streets of Berlin yesterday, and people from all walks of life, from all parts of the world, are here in Berlin. It's a multi-ethnic city. And this is a cover from a British Medical Journal article, and you can see this variety now. Blumenbach didn't see the variety, but he read about it. He looked at skulls from all over the place. He talked to a lot of people. He was a proper scholar. He's one of the most distinguished doctors of his time. He was a physiologist, anatomist, anthropologist, physician. He was a physician to the King of England, and he traveled everywhere. He got 83 honorary titles from learned societies across the world. Well, let me come to immigrants and ethnic minority groups. And here we have a sort of definition from the Oxford English Dictionary. Excuse me, I'm going to get my reading glasses in there. I can't read very well. Julia has already learned that I'm actually partially sighted, and that's just a fact of life, so my vision is very poor. So the definition here is that immigrant, one who immigrates, descendants of recent, especially coloured immigrants. This is so incredibly important. The immigrant is not a neutral term. Immigrant and ethnic minority health cannot be disentangled. The issues change across generations. The kind of things we're interested in now are not the kind of things we were interested in the past. And I will show you why that is the case very soon with a picture of Irish immigrants. So what is race then? Well, that's a very contested matter. It's one of the most controversial concepts in the world. Traditionally, it's been the group you belong to because of the way you look, the kind of type of hair you have, the facial features, the colour of your skin. And these are ancestral matters. Increasingly, in the last 70 years in particular, social and political heritage of a group. And this concept is discredited in Europe, but it's being replaced by ethnicity in some parts of Europe and by migration status measured by country of birth or parental country of birth in other parts of Europe. So let me turn to ethnicity. Ethnicity is a much more complicated idea. It's the group you belong to or are perceived to belong to. See, I can tell you I'm Scottish, but you won't believe me. You won't perceive that. I could tell you I'm Indian, and you'll say, but why do you have a Scottish accent? So that's a bit awkward as well. So I have to tell you I'm a Scottish Indian. It begins to make sense. I was brought up in Scotland. It's a group you belong to or perceive to belong to because of your culture, language, diet, religion, ancestry, and physical features. It all goes together. So you can see that you cannot disentangle race and ethnicity either. There is an overlap. So let me then turn to the overview of the issues that we will be discussing, and this overview comes from the abstract I submitted, and again, you're welcome to have my abstract if you would like to have it. Right, I'm not going to move away from this microphone. That's why I'm reading rather than reading from there, because vision is not good enough to read. And if I look up there, then you won't hear me properly. So it's the analysis of the differences between people that underpins population sciences. And differences are analysed using variables such as age group, sex, socioeconomic status, cigarette smoking, alcohol consumption, behavioural factors. These are the kind of things that are going to be central to your Einstein Centre and the Ethics Task Force. Understanding why these differences occur and treatment effects is very valuable in public health, epidemiology, medicine, and other population sciences. I have written very extensively on the value of this work, and there are whole books devoted to it. This is one of the most comprehensive on what differences there are and why they are there. You can read a lot about it. I don't want to overemphasize this because I've been over that many times and many scholars have been over it. But without giving you a few examples, you won't be convinced. Not all of you will be convinced. Let's take the word Asian. In the UK, Asian means people from the Indian subcontinent. The same word means in the United States, it means people from the Far East, China and Japan. So in the UK, research was done on Asians, Indians, Pakistanis, Bangladeshis, Sri Lankans, all combined. In the Newcastle Heart Project, which we did in the 1990s, we came to this extraordinary result. It truly is extraordinary because when you put Indians, Pakistanis, and Bangladeshis together, and you look at their smoking prevalence, 33% of them smoke, compared with the Europeans, 33%. So for the men, you would conclude there's no difference. For the women, there's a big difference, whichever group you're in. But when you look at the men disentangled, you can see the Indian, Pakistani, and Bangladeshi groups are very, very different. So you can't conclude that smoking's not a problem in South Asians as it that was a previous conclusion until we published this work. The other thing I hear all the time, whether it's from epidemiologists, whether it's from the public, minorities have got poor health status and poor people, we have to do something about them. It's as if they were falling apart. Well, we've done a lot of research on this topic in the UK, and especially in Scotland, Scotland's been a leader in this work. We examined life expectancy in Scotland. And what we found was the longest life expectancy is in minorities. Indians, Pakistanis, Chinese, they have longer life expectancy than the white Scottish population. They are not falling apart. They're robust, strong, long-lived, doing very well. That doesn't mean to say there aren't issues. There are some issues, which we'll come to. How could we actually learn this without having some way of ethnic group categorization? And if I use the word ethnic group in the German context, you could, for the moment, migrant status categorization or something, or whatever is your preferred method. So this is my third slide, because in the COVID pandemic, there was a very widespread view that COVID was not hitting people equally. And the UK was one of the only places in Europe that could actually almost instantly produce the data to show this was true. This is a bar chart showing the differences in COVID by ethnic group. And we could do it because we've been working on this for 50, 60 years in the UK. And we actually can link the census, which contains ethnic group data, to health databases. And the next slide is for you, not for you to read, but to show you something, that in Scotland, we have examined 29 health outcomes using the ethnic group data from the census. And what we find is, for the different outcomes, red means bad, green means good. There's no ethnic group which is uniformly bad. There is no ethnic group which is uniformly bad. The pattern is incredibly complex. That's the only message from this slide. Do not generalize, do not stereotype. You will get it wrong if you do that. Let me then continue with that overview, because the overview is not all about how useful these data are. Variables describing ancestry, physical features, national origins, culture, and religion are. I don't need to tell you, you know this already, that's why I'm here. Very, very controversial. And they're so controversial that in different countries, almost neighbors, they will use different words for them. So one word is acceptable in one country, but it's not in another. But the concepts are global. The concepts have been here from time immemorial. They are called universals. There are things that are found in every society anthropologists have studied. And the concept of us and other is in every society. The other concept that's in every society is ethnocentrism. That is the view that the way we do things is the best way of doing things, and everyone else's way of doing things is inferior. That's a universal. These concepts are universals. So I've already said one country might use nationality or country of birth, another might use race or ethnicity. These are incredibly dangerous variables when misused. Mostly, people will point to the deficiencies and problems in a particular group. In Scotland, we have been very fortunate through the Scottish Health and Ethnicity Linkage Study to be able to study many variables. And indeed, in some aspects, the ethnic minority groups in Scotland are worse off. For type 2 diabetes, they're much worse off. But for lung cancer, they're much better off. So if you don't produce a comprehensive picture, you come to the wrong conclusions. These variables have been used to justify slavery. African people, black African people, were exported in millions in their slaves, as slaves. The number of deaths was probably on a par, if not far more, than the Holocaust. That's just people who died on the transatlantic crossing. It was justified on the basis they were an inferior type of human being. Perhaps not even part of the Homo sapiens group, because at that time there were a lot of people arguing that humans were not just one species, there were several species. And imperialism was based upon classifications, very complex classifications, putting people into a hierarchy of worth. The British did that in India very extensively. And then they would pick the people they thought were slightly better amongst the Indians to serve in the Indian army. So then we have immigration control. The United States decided that Jewish people were inferior, and they actually banned Jewish people from entering the United States. There was some act around about 1922. It took many decades before that act was lifted. Then racism. We justify racism on the basis of inferiority of some people. And the Holocaust, well, I don't need to tell you anything about the Holocaust. You know far more about it than I do. Now, if you want to read a good book, and this is a Christmas cracker actually, put it into the stocking, it's this book. And it's deliberately called The Mismeasure of Man, because it's mismeasure of males by males. It's about how scientists decided that some groups had inferior IQs, and they did all the research to more or less justify their conclusions, which were completely wrong. But this was a major industry in the 19th century. Let's continue with the overview. So there are potential harms and there's potential benefits of these variables. But one of the things we find, and you'll find this, is that there's adverse public and media attention when differences are demonstrated. It's not neutral. If there's a problem, the newspapers will really latch onto it about how the health service has to spend so much money doing this, that, or the other, whether it's sickle cell disease or whether it's type 2 diabetes or whatever. When you demonstrate that lung cancer rates are low, there's nothing, absolutely nothing about that. So you don't get a balanced picture. If we try and do something about an inequity, and it gets into the newspapers, there's a backlash. We've just had a major backlash, which has been in huge amount of news coverage in the last 2 or 3 weeks in the UK. The Sentencing Council is made up of the most senior judges in the country. They commissioned a report that showed that minority ethnic groups were getting longer sentences than the white British majority for the same crimes. And there was an injustice there. So the solution to the injustice was that certain types of people should have a pre-sentencing report that guides the judge. Amongst the people who needed a pre-sentence report were pregnant women, because the Sentencing Council's report said they were being punished more harshly than they should be. Anyway, this got picked up by the right wing of our political government, of our government, or was the opposition now, and it got picked up by the right-wing newspapers. A huge storm. The sentencing guidelines were supposed to come in yesterday, and the government said, we are going to rush out emergency legislation to block these sentencing guidelines. That's their own sentencing council that they've appointed to do the job. And as soon as they do a job that might help people from minority groups, they're going to rush out emergency legislation to stop it. So the Sentencing Council backed down yesterday or the day before and said, we'll suspend these guidelines for 2 years and we'll see what happens. Another example is as soon as a hospital puts in interpreting services, and if it gets into the newspapers, the headlines will be about millions of pounds are being wasted by people who won't learn English. And it's not so easy to learn English. I can tell you, I'm a doctor, I speak Punjabi. I do not have the language to speak about the pancreas or the kidney or the corpus callosum of the brain. I can tell you what I'm having for dinner in Punjabi. It's not easy to learn the language for this. So that's an example of interpretation. In societies promoting equality, these variables are very helpful. and they help to improve societies. But if that's not true, don't do it. If the Alternative for Deutschland is going to be in power soon, this is a very dangerous time to pursue this agenda. If we had Robert Jenrick, who's a Conservative senior politician in power as a Prime Minister, I would be worrying about ethnic coding in the UK. You know, it depends who's there. If Nigel Farage and Reform Party gets into power, I might have to change my opinion. But currently, we're fine. And that brings me to the issue of a core aspect of ethics, i.e. beneficence. Beneficence is do good. One of the aspects of medicine is don't do any harm. Of course, we do a lot of harm, as we learned in that museum tour for those of us who were there. And we should be doing good. The concept of beneficence is more important, more powerful than law and policy. If you have that concept of beneficence in society, you can work. Without it, you can't. If we are a benevolent society, that requires that minorities are not excluded from the good in society. And one of the goods in society is research. People who participate in research benefit as individuals, and they also benefit the society that they come from. Research is a good, but beneficence towards minorities is not universal. Now, I want to show you this picture I took myself. It's taken in Liverpool. It's Irish immigrants leaving Ireland after the Great Famine. But after Ireland was England's first colony and the first to gain its independence in 1922. It was colonized in the middle of the 17th century. It was a very thriving country, but after this colonization, it really went downhill. It had a population of 8 million at one time. I hope it's never recovered that population. These are Irish immigrants leaving Ireland. They went to Liverpool. They got the ships to go to America. You might think they were white, so they were being widely welcomed. They were not. Even in Scotland, they were treated like vermin. The Registrar General is the most important statistical officer in the country. Annual reports would talk about how these people are sapping everything good in Scotland. You can't believe the racism against the Irish, and the Irish know about it. And this antipathy to immigrants, migrants, no matter how difficult their circumstances, continues to this day with the British policy now, the British Conservative Party's policy for transporting asylum seekers to Rwanda has now thankfully been put aside after spending probably £250 million the Conservative government spent on that. Only one person went voluntarily, and now the whole policy has been scrapped. So there's a lot of antipathy towards immigrants, but that's historical and it continues to this day. Let's look at the legality of it all. In 1997, the EU member states signed the Treaty of Amsterdam. Article 13 gives the powers to combat discrimination on a number of grounds, including the ones we're talking about. The UK implemented this with great enthusiasm. We had a Race Relations Amendment Act in 2000. We had a public sector duty to promote equality. We had an Equality Act 2010, which widened it. And there was a universal acceptance that data were required to underpin action. Well, that data are required is very well known. This is actually the cover of the 1983 World Health Organization consultation on migration and health. And you can read a whole chapter telling you about the importance of data and why it's required. And that's ethnic group coding or racial group coding or country of birth coding, and analysis of such data and utilization of such data. A whole book, and a huge amount of it is to do with that. Nothing much happened except in one or two countries. And in 2010, we have another WHO consultation. In the meantime, we'd had the World Health Organizations Assembly, I think it was 2008, had a resolution on these issues and said data are required. Well, here we have another report. It's interesting, isn't it? The previous slide, it's in shadows. The migrants are in shadows. And in this slide, the migrants are in shadows. It's symbolic, really. Then, this global consultation in 2010 said there should be a standardization of methods and definitions. We should integrate monitoring into existing systems, engage target populations. There should be a global working group and clearinghouse. We should examine patterns globally, and we should use these data for health and healthcare improvement. Well, it's wonderful. We should, shouldn't we? I don't think there'll be many people who disagree. Right, so let's just think about if we did want to do all that, what do we need? Well, I think times have moved on since Blumenbach's day. And in the modern day, we have established some principles that are very widely supported, certainly amongst researchers and scholars and professionals. And the first principle is it should be based on self-definition. No one should be able to tell you who you are. You tell others who you are. I've already told you, I'm an Indian and I'm Scottish. I'm a Scottish Indian. Don't disagree with me. Then it should be collected with informed consent. People should know why these data are being collected and what they'll be used for. The categories need to be agreed widely. Data should be collected once and once only. You shouldn't need to be asked 20 times. Probably they should be collected in primary care and transferable into other places. They should be collected by fully trained staff. Staff don't like to collect these data. Some staff wonder whether it's racist to collect these data. They feel uncomfortable, so training is required. What we learned in Edinburgh, we did a lot of work in Edinburgh on this topic, is that something like 1 in 10,000 people feels unhappy about it. And nearly all of them are what we call white Scottish people. The minority understand exactly what this is all about, and they don't mind giving the information. We should record everything needed for appropriate care. It's just not just enough just to have ethnic group or migrant status. You need the heritage background, you need the religion, you need the language. In the question and answer, we might be able to disentangle some of that, because I don't want to take up all the time without giving you a chance. In the EU, we did this project. It was Nazmi Villarreal was from Edinburgh, was our research fellow who did this project. It was a worldwide project. It was run from the US. We were the European branch. I was the principal investigator of the European branch. We had many investigators from across Europe. And I've given the reference for this project. The European bit was published in the European Journal of Public Health. What did we learn about the 28 EU countries at the time? Very patchy data collection. And when I say ethnic categories, I also mean country of birth, for example. Where recorded, the categories vary widely. They're conceptualized in very different ways in terminology. They're influenced by historical events, politics and legislation, ideology, sensitivity towards cultural identity, ongoing migration patterns. We couldn't specify from our European work what would be the ideal way to go forward, but we concluded that we needed to simplify matters, identify the problems, and share good practice and principles. To some extent, I'm here doing that. Right, so I'm going to talk about just a very little bit about Germany, because I tried to learn a little bit about Germany before coming here. Last time I came here was to give this kind of talk was 2003, where I was asked to describe the UK system. So it was not a broad-ranging talk like this one, so I felt I had to learn a little bit. In my book, I don't talk a lot about Germany except for what happened in Nazi times. I do speak a lot about Hitler in my book, I've also published a paper on Hitler's views on race and health. It's published, and the reason, I'm probably the only person who's actually read Mein Kampf. I've never met anyone else who's read it. Everyone knows about it, but no one's read it. It sat on my stairs for 6 weeks before I could find the courage to pick it up. I paid quite a few library fines, and then eventually did read it, and then I wrote this paper. Right, what I learned is there's a tremendous debate going on. Mostly, it's not developing very fast. It's largely in academia, and there's quite a lot of sensitivity about it, how you collect anti-discrimination data. And in this article by Katja, is the one who is not counted does not count. It's so true. If you're not counted, you're hidden, forgotten. And data must be collected, there must be equality data for equal social participation for the reduction of health inequalities. So that article is worth reading. I'm now going to say a little bit about the United Kingdom because I think it is a good case study. Yes. Thank you very much, yeah. Just as well I told you that my vision is very bad. Right, here we are, the United Kingdom. Right, okay. In the United Kingdom, as in most countries, the census records country of birth, sometimes nationality, and we've had that question since 1841. By the way, our census is not like yours. Ours is a questionnaire. It comes into every household. The head of household has to fill it out on behalf of everyone in that house. It's a legal requirement. If you don't fill it out, you can be prosecuted. It's a very different affair to your so-called administrative data census. Not the same at all. So we collect country of birth from then. A direct question on ethnic origin was included first in 1991. But Parliament gave the permission for that in 1921. It took 70 years from Parliament giving permission to it first being enacted. Now, why did we need it? Because most of the people who said they were born in India were British colonists. So we couldn't say anything about the Indians, real Indians living in country of birth was useless. Even now in Scotland, when we were doing our research, we found the vast majority of people over 70 in Scotland who were born in India were white Scottish people. So when we're studying these diseases like cancer, which are diseases of old people by country of birth, it was totally useless. So the ethnic group question was developed after extensive consultation. When I say extensive, I'm talking about tens of thousands of people. Millions of pounds were spent on consulting with tens of thousands of people and trying out pilot studies. This was the first question devised in 1975. I'll let you read it a little bit. You can see what it's like. This was going to be used in the 1981 census. Unfortunately, there was a politician called Enoch Powell who gave a very inflammatory speech about how Britain was becoming the kind of country with so many ethnic groups that our rivers would be filled with blood from civil unrest and fighting. He was completely wrong. Unfortunately, he's dead, so he's not been able to see that he was completely wrong. But would a politician ever admit that they were wrong? Probably not. So this was the question. It was never used because there was such worry about the times that we never used it. The census didn't include it. So we developed it. It was in 1991, and then we developed it further in 2001, then further in 2011 and 2021. And in 2021, we've got ethnic group, national identity, religion. By the way, who do you think thinks they're British more than any other country? The minorities. The ethnic minorities think they're British, whereas the white Scottish people think they're Scottish, and the Welsh think they're Welsh, and the English think they're English. They don't think they're British. It's very interesting. The country wants everyone to think they're British. Religion is included, main language, and the proficiency in English. It's incredible how it's changed. And this is, again, it's not for reading, but you can see that the census question looks like this. Our census is about a 32-page questionnaire. A couple of pages, 3 or 4 pages are devoted to these kind of questions. And that's a slightly more, just to see what it says about Asian. So I've already said I'm a sort of Asian. So you can be, where would I fit? I would fit, I'm not Bangladeshi, I'm not Chinese, I'm Indian. Number 3, Asian, Asian British, Asian Welsh, or Indian. That's where I would fit. That's where I would fit myself. So what are the challenges for research in this field? Well, firstly, we have to present the research in a way that achieves benefits for the population studied. But also, it can achieve benefits for the entire population. So, for example, we have published data showing that in the Pakistani population, they have very low rates of colorectal cancer, even though they are red meat eaters. Now, why is that? It's a very interesting epidemiological question. I have published an explanation in the Journal of the American Medical Association. My hypothesis, and it needs to be tested, is that they eat halal meat. They only eat fresh meat. They don't eat processed meat. And we know that processed foods, especially meats, are very bad for you, whether it's cardiovascular disease, diabetes, or cancers. So Pakistanis don't eat these processed meats. So that's a very interesting thought. You know, the whole population could benefit from this kind of research, trying to understand these cancers. But certainly the population that's done it, is involved in the research, they should benefit. And the research has to avoid stigmatization and racism as a result of that. We have to stimulate appropriate policy and service activity that follows the research. It's not enough that the research is done and published in some distinguished journal. And can I just confess, I'm as guilty as anyone, because as soon as my paper is published, I'm already got half a dozen others that are in draft. So I'm straight on to the other one. It's only in my later years as I matured and coming close to retirement that I even started to read my own papers once they were published. I made a little bit of a discipline that when my paper was published, I would reread it to remind myself what was in it. Even that, I think a lot of people don't bother to do. And then even I matured further, then what do we do with this information? We'd make sure there's a press release or call a meeting of someone or send it to people. I would send the papers to the chief medical officer or the director of public health. So we have to stimulate the appropriate policy. And then we have to integrate the research with law. What's the implications? Policy, service action, service plans. That's where in the UK academic doctors have a bit of an advantage, because nearly every academic doctor has also got a service contract with the National Health Service. So I've always had, in addition to my academic contract, a duty to serve the National Health Service, and the amount of work I'm supposed to do for the National Health Service is prescribed. I'm told how many hours I have to spend, and then we negotiate what I actually do. So I've always known what's going on in terms of the National Health Service, and they know what I'm doing, and I have a route for my research. I can speak to the Director of Public Health. This is what I've done, and this is what the implications are. So my penultimate slide is healthcare challenges for a multi-ethnic world. So we have to get ready. Well, no, we should have got ready 50 years ago, maybe 100 years ago. But certainly it's never too late to get ready. We have to get ready to respond to the varying health behaviors, beliefs, and attitudes that we see all around us. So I've spoken a little bit about British Pakistani people. They're tremendous when it comes to alcohol. They hardly drink any. The ones that do drink too much, but very few of them drink alcohol. They seem to have a pretty healthy diet. But they're not good when it comes to, males are not good when it comes to smoking. So, you know, we have to think about the different kinds of behaviors. Then we have to look at the differences in the pattern of diseases. So that's a very public health approach, which I've actually talked about already. We have to listen to calls for services that are adapted and responsive to cultural and other differences. And although I've spoken about health, exactly the same applies to education, housing, the law, and all the other important public services. So my talk could be generalized right across all these other areas. The difference is the health sector is 20 or 30 years ahead when it comes to research on these matters, compared with all these other sectors I've talked about. Health has been in the forefront, and we've been studying within the health field these matters for probably about 150 years, long before we were born. We have to confront our personal biases, our stereotype views, our individual racism, and our institutional racism. Now, I've spoken a lot about racism, and I've written a lot about racism. And you might think that someone who's brought up in Scotland with a Scottish accent wouldn't be subjected to racism. And I've written about my own experiences, how I was called a darkie virtually every day when I went to school in Glasgow. How my wife and I couldn't buy a house because at the very last minute, after we had made our offer had been accepted, a neighbour complained to the person that was selling the house to say they didn't want to live next to an Indian. That was in 1983, so it's not that long ago. It's long after Britain banned any such behaviour. And how I haven't received jobs in various kinds. I must say I've been very fortunate in my medical profession. I can't complain about that, but other places. So we're all subject, and I'm not free of it either. I have loads of biases in my head. Some of them inserted in there by my parents and my family and my community. So it's very difficult to get them out. I mean, I'm an Indian, I'm a Sikh, you can tell that from my bangle. And we have been mortal enemies of Muslims, much more than Europeans versus Muslims. Honestly, it's a different order of conflict historically. And I was brought up in a community where every single day my parents or my uncles or cousins would be making very strong anti-Muslim sentiments. And getting all that stuff out your head when you become an adult is incredibly difficult. So I'm conscious of that. I do my best. And then we need laws promoting equality and equity in services and employment opportunities. As a public health doctor, I can tell you that the things that work in public health are policies underpinned by the law. Virtually everything else fails. And so remember that. And here, where we're going to then, we want to move forwards. And moving forwards does require empirical data. And it does require the use of these kind of classifications we've talked about. This is on the left-hand side, there's the 1983 WHO report. We have to move from there, and we have to move to the right, where we accept that we're living in a multi-ethnic, multicultural world. We have to move forwards and energize each other and help each other and benefit each other and live together, work together and understand each other. And data are required to understand each other. Can I just say that slide is not new either? That's the WHO's call for all for health and health for all. That's from about 1980. So yes, I am an old man, but nonetheless, this thing reminds us that these are ongoing agendas. They're not just something that's been dreamt up in the last few years. So with that very positive image, I'll stop there and take questions. Thank you.